and hello to everyone who's preparing for the Mrcp cases. So today I'm going to discuss a bit about the Mrcp cases consultation station, and we're going to talk about ankylosing spondylitis. So let's move on with the presentation. So as usual, first I have put some patient information here. So this patient is Mr. John Smith. He's 30 years old male, and he's an office worker, and chief complaint is back pain and stiffness. So same thing, they will give you some scenarios. So you know already that now we are dealing with actually back pain, so it's a musculoskeletal system problem. So here's a presentation. Mr. John Smith presents to your clinic with a complaint of back pain and stiffness for the past 7 days. When you are reading the scenario, focus on the buzzwords. What is the buzzword here? The buzzword here is stiffness. He described the pain as mainly located in the lower back and buttocks. He also mentioned that the pain is worse in the morning and improves with activity. Another buzzword, worse in the morning and improves with activity. Mr. Smith admits that he has been experiencing difficulty in bending and tying his shoelaces. So there has been some problem with the movements are quite restricted. So from this scenario, you already have an idea. We're dealing with the musculoskeletal system, and most likely you'll be dealing with in this young patient, ankylosing spondylitis, because he has got stiffness and it's worse in the morning and improves with activity. Okay, let's move on with the history. So once you have read the scenario, and if you are in the consultation station, then you have to take a good history. So how we'll take the history? I have again divided into different sections. So try to memorize all these sections so you don't miss anything while taking your history. So we'll start with Mr. Smith. Okay, Mr. Smith, thank you for coming to the clinic. Can you tell me what brings you here today and the specific symptoms you are experiencing? Now, when you put this open-ended question, the patient will volunteer all the information which he can give to you without any prompt, because there are some questions or some information which he will reveal only when you ask, but some information they will just give voluntarily. So just listen to the patient and don't interrupt him. Now, moving on, we want a bit more detail about the presenting symptoms. So, Mr. Smith, you have mentioned back pain and stiffness. Can you elaborate on these symptoms, their location, and when they first started? Another question, how would you describe the nature of the pain in your low back and buttocks? Is it sharp, dull, or aching? Another question, do you notice any variation in your pain throughout the day or with different activities? And then you'll ask about the morning stiffness. Very important, this question. You mentioned morning stiffness. How long does this stiffness usually last? And does it improve with movement or activity? So try to get as much as information from the chief complaints, but asking each symptoms individually and all the relative questions. Then we'll move on, and we want to talk about a family and personal history. So any family history of ankylosing spondylitis or low back pain? Have you had any other medical conditions or surgeries in the past? And are you currently taking any medicines or having any known allergies to medications? Allergies to medications, every patient must ask. In this case, is more important because you know that for ankylosing spondylitis, we're going to prescribe the non-steroidal anti-inflammatory drugs. It's very important that you must know all the allergies which patient have. We're going to ask him about the back pain characteristic. Please point to the specific location of a pain in your lower back and buttocks. Have you experienced any radiation of pain into your legs along with numbness, tingling, or weakness in the legs? So we have to rule out the other differentials as well. Has there been any recent injuries or trauma to your back? Then we want to talk a bit about the mobility and functions. So Mr. Smith, you mentioned difficulty bending and tying your shoelaces. How do these symptoms affect your daily activity and overall function? So to get an insight about how the symptoms are affecting his activities of daily living. So have you noticed any limitation in your mobility or difficulties in performing tasks both at work and in your personal life? Do your symptoms interfere with your sleep or any recreational activities you enjoy. So ask about these things. Then we want to talk a bit about the past medical history. Can you provide me more information about the general health, any previous surgeries, or any significant illness in the past? We'll ask about the smoking history and about any medications, including over-the-counter and supplements. And finally, we're going to talk a bit about social history. Could you describe any physical activities or hobbies that you regularly engage in? What is your current occupation, and does it involve any physical demand, or do you have any specific questions or concerns related to your condition? So this is briefly about the history. So try to remember all the points so you don't miss anything and take a complete and thorough history. Now I will just put some information about the differential diagnosis, because this patient, although you know from the presentation that we are talking about ankylosing spondylitis, but in the exams you have to show to the examiner that you are thinking about all the differential diagnosis. So you have to ask all the relevant questions and do the complete physical examination. So what could be the causes of the back pain in a young patient? So I'll just put few differential diagnoses here, like mechanical low back pain. Well, it can cause stiffness and discomfort as well. Often it is because of the muscle strain or poor posture. However, what is the differentiating point? It's not really associated with morning stiffness and tends to improve with rest. Another differential is inflammatory joint diseases. Now, various inflammatory joint diseases like psoriatic arthritis or reactive arthritis, they also can present with same thing, with back pain and joint stiffness. But however, remember, these conditions may be associated with skin rashes. Like in psoriasis, you may have a rash, you look for a nail pitting, nail changes, or other systemic symptoms. And for the reactive arthritis, obviously you're going to ask about the history. Any joint pain, back pain, you ask I have not mentioned it, but ask about the sexual history as well, very important. Ask about any previous history of dysuria, gastrointestinal infection, any eye signs like this. What could be the other differential? Sacroiliitis. Now, which sacroiliitis may be isolated or part of a broader condition. It can cause symptoms similarly to ankylosing spondylitis. So it typically actually involves inflammation of the sacroiliac joint and can occur in conditions like psoriatic arthritis or inflammatory bowel diseases. Then another differential is mechanical sciatica. The sciatica can lead to radiating pain from lower back into the buttocks and legs. It often results from compression of the sciatic nerve, and maybe because then herniated disc or spinal stenosis. So sciatica is also one of the differentials. Infectious spondylitis, infection in the spine, like vertebral osteomyelitis or discitis, they also may lead to back pain and stiffness. However, remember that infectious spondylitis, they are often associated with other constitutional symptoms like fever, localized tenderness, and a history of recent infection. Well, lumbar disc herniation, which can cause low back pain and may lead to nerve compression, resulting in leg pain, numbness, or weakness. The condition will also treat the specific pattern of pain distribution. Fibromyalgia can cause widespread pain, including in the lower back, but it is characterized by some tender points, fatigue, and sleep disturbances. Non-radiographic axial spondyloarthritis. This is actually almost the same entity. It shares some features with ankylosing spondylitis, but may not yet show the characteristic radiographic changes. It is considered a milder form of axial spondyloarthritis. What about other inflammatory conditions? We'll be thinking about rheumatoid arthritis, which can occasionally present with back pain and stiffness, although it more commonly affects the peripheral joints. There could be referred pain from internal organs such as kidneys or GI tract, can sometimes be perceived as lower back pain. Obviously, thorough history and physical examination necessary. And finally, the musculoskeletal disorders like traumatic injuries, they can mimic the symptoms of ankylosing spondylitis and should be considered in the differential diagnosis. So I put almost 11 differentials here. If you remember 5 or 6, it is enough already. Okay, let's move on now. Now you've taken a complete history. And so history, remember that I already told you a few points which I have not mentioned, but you have to ask them also. It depends on the because there are so many causes of the back pain. So it depends on the scenario, what the patient volunteer the information in the first instance, and from there you can take up, and then you can try to work through your differential diagnosis so you can come across your final diagnosis. So examination, obviously going to do the general inspection first. Posture, you look for any signs of stoop posture and reduced lumbar curvature, which could indicate a loss of spinal mobility. So in the ankylosing spondylitis, there are typical stoop posture called question mark sign, and it is usually quite obvious if it is really advanced. Gait, we observe the patient gait for signs of stiffness and limited hip movements, and obviously on the skin we want to check for any rashes like psoriasis, which can be associated with ankylosing spondylitis. Not especially, but it comes in the differentials. Okay, so once you have completed your general inspection, then we move on and we want to do the musculoskeletal examination. We want to check the spinal mobility. So ask the patient to bend forward, and then you can do the Schober's test to assess the lumbar flexion. So normally there should be increase in distance between two mark points in the low back, and we assess the also we'll assess the lateral flexion by asking the patient to bend sideways. So check for the spinal mobility first. Chest expansion, major chest expansion during deep inspiration and expiration. So reduced chest expansion may indicate involvement of the costovertebral joints. We want to do the sacroiliac joint examination. So there is a test called Patrick test or Faber test to assess the sacroiliac joint movement. This test may not be necessary in the MRCP basis examination. However, you must know about this test. In this, what happens, the patient lies supine, and the examiner flexes, abducts, and externally rotates the hip, causing pain if the sacroiliac joint is affected. So whatever tests which could cause pain, we tend to avoid them in the MRCP cases. So then you do the peripheral joint examination. We check for signs of any peripheral arthritis, especially in the hips and knee. We want to assess the tenderness, swelling, and restricted movements in the affected joints. Some of the special tests, modified Schober's test, which measures, I already mentioned about this very important test, measures the lumbar flexion. Normally the distance between two mark joints in the lower back increases. Occiput to wall distance, chest expansion measurement, and finally neurological examination, peripheral neurological assessment. So assess for any signs of radiculopathy or peripheral nerve involvement, especially in the lower limbs. So in brief, what you can do is we start with inspection. We'll move on to the examination of the spine, do the joint mobility that I mentioned already, look for any chest expansion, look for, in the general physical examination, look for any rashes or anything. We'll do the Schober's test, we'll do the occiput to wall distance, and then do the neurological examination of the lower limbs. Okay, so just check normal, check tone, power, reflexes, and the sensory modalities, check all four modalities. So this will be the complete examination for the patient with suspected low back pain and ankylosing spondylitis. Okay, what are the investigations? I put the another section for investigations. You must be familiarized with the investigations. So important is X-ray of the sacroiliac joint, and this is the primary imaging modality. So look for any signs of sacroiliitis. Like sacroiliitis means there will be erosions and joint space narrowing and sclerosis. So remember that early in the disease, these changes may not be evident. The other X-ray we want to do is lumbar spine X-ray, and we want to see the characteristic findings like bamboo spine and ossification of the spinal ligaments. But remember, these changes occur later in the disease. But you must know that on the X-rays, we want to do the X-ray of the sacroiliac joint and the lumbar spine. What about the blood test? We want to do the HLA-B27 genetic testing, and this genetic markers is strongly associated with ankylosing spondylitis. However, its presence is not diagnostic on its own. Okay, so we have to combine all the things: the history, the X-ray findings, the clinical examination, and on top of it, you got HLA-B27 positive also. Then you can confirm your diagnosis. We want to look at the inflammatory markers like ESR and CRP, and elevated levels can support the diagnosis, but they are not specific. We want to do the CBC also to rule out other conditions and assess for any anemia, and kidney and liver function test to ensure overall health and assess the effect of the medications if your patient is on NSAIDs on these organs. So radiological studies, blood tests, and then we do the MRI. Now MRI of the sacroiliac joint and spine, particularly it is helpful in the early stages of ankylosing spondylitis when the X-ray changes may not be apparent. So MRI can reveal the active inflammation in bone edema. Then we want to do the assessment of the disease activity. Now these are some sorry, like Bath ankylosing spondylitis disease activity index. And this is a patient-reported questionnaire which assesses the disease activity, including the pain, stiffness, and fatigue. If you know, if you remember the name, that is very good. Just mention it that you'll assess by using this Bath ankylosing spondylitis disease activity index, and other is Bath ankylosing spondylitis functional index, and this tool evaluates the functional limitations and physical ability. What about HLA-B27 subtyping? It can provide further information about disease risk and potential disease manifestations. We want to do the eyes examination. You know that ankylosing spondylitis can be associated with the uveitis. So an eye examination may be recommended to assess for eye movement. Additional tests, we can do the CT scan, which can provide detailed images of the spine and sacroiliac joint, which may be helpful in specific cases. Bone scintigraphy, a nuclear medicine scan can help detect areas of active inflammation in the skeleton. Gastrointestinal endoscopy in some cases, because this ankylosing spondylitis may be associated with inflammatory bowel disease. If there are gastrointestinal symptoms, then endoscopy must be considered. And finally, pulmonary function tests. These are helpful if there are symptoms suggesting lung involvement. Now, important thing to remember is that there is no single test which is diagnosis of ankylosing spondylitis on its own. So diagnosis is actually based on a combination of clinical findings, imaging blood tests, and the exclusion of other conditions. So the assessment should consider patient history, number one, family history, and symptomatology. And the role of each investigation may vary based on the clinical presentation and the stage of the disease. So this was briefly about the investigations approach. What about the management? Management, I have divided the management into different sections: medicines and physical therapy and exercise. So medicines, we all are aware that non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, these are the first line treatment, and they help reduce pain and inflammation. However, the long-term use, we need to be monitored for potential side effects, particularly on the gastrointestinal symptoms. What about disease-modifying antirheumatic therapy? So in case of more severe ankylosing spondylitis, and if non-steroidal anti-inflammatory drugs alone are insufficient, disease-modifying antirheumatic drugs like sulfasalazine may be considered. And however, remember, these are more commonly used in peripheral arthritis associated with ankylosing spondylitis. The other group of drugs is biological therapies for patients who more severe refractory ankylosing spondylitis. Biologic medications like tumor necrosis factor inhibitors, adalimumab may be prescribed. And these drugs, actually target the specific components of the immune system to reduce the inflammation. Close monitoring of side effects and infections is necessary with biologics. Physical therapy and exercise. Well, physical therapy plays a crucial role in ankylosing spondylitis management. It helps maintain the joint flexibility, it improves the posture and reduces the pain. So we have to make a tailored exercise program for the patient. And swimming is often recommended due to its low impact nature. What about posture and mobility? Emphasis should be placed on maintaining good posture and body mechanics to prevent the development of a stoop posture. And use of lumbar rolls and ergonomic workstations may be beneficial. Patients should be educated about ankylosing spondylitis and its management, and should understand the importance of exercise and the benefits of maintaining a healthy lifestyle. What about surgery? Well, surgery is rarely required. In severe cases of advanced subspinal involvement, like spinal fusion surgery, may be considered to correct deformities and reduce pain. Obviously, it has to be assessed carefully, and consultation with the spine surgeon are necessary. Uh, Uveitis is present. Prompt treatment by ophthalmologist is essential. Patient, we have to think about some psychological support. Living with the chronic conditions like ankylosing spondylitis can be challenging, so patient may benefit from psychological support and counseling to cope with the emotional aspect of the disease. Lifestyle measures: smoking. If the patient is smoking, remember that smoking can worsen ankylosing spondylitis, so quitting is strongly recommended. Maintaining a healthy diet, regular exercise, and normal body weight can support overall well-being. And finally, regular follow-up. Long-term management of ankylosing requires regular follow-up appointment with a rheumatologist to monitor the progression of the disease and just treatment as needed. And obviously, we have to monitor the side effects of medications is essential. Now, I have put a bit detail about the disease-modifying anti-rheumatic drugs because the examiners can ask about this in a bit more detail. So, disease-modifying anti-rheumatic drugs like sulfasalazine may be considered in cases, especially if the disease predominantly affects the peripheral joints like knees or ankles. And these drugs are typically used, I already mentioned it, that when NSAIDs alone are not providing sufficient symptom relief. And sulfasalazine is commonly used, although methotrexate can also be considered. What are the limitations where these are not as effective in controlling the spinal symptoms of ankylosing spondylitis as biological therapies? Their primary role in managing peripheral is in managing the peripheral arthritis associated with the AS, and the onset of action may be slower compared to the biologicals. Monitoring and follow-up. Regular follow-up with the rheumatologist is essential to assess the response to this therapy. Monitorings include evaluating the control of peripheral joint movements and assessing for any side effects. So we have to do some blood tests, including the liver function test and complete blood count, these to monitor the potential side effects of these drugs. What about the biological therapies? Well, biological therapies are typically reserved for severe or refractory cases of ankylosing spondylitis, and the primary biological agent used is the tumor necrosis factor inhibitors such as adalimumab and infliximab, etanercept. And these agents, are indicated when patients have not responded adequately to NSAIDs or when the disease is causing significant spinal inflammation and stiffness. They do have some limitations. Biological therapies, they are expensive and access to the medication may be limited by insurance or healthcare system. There is potential for increased risk of infection, including the reactivation of latent TB. Patients are often screened for TB before starting this medication. And like all medications, biological therapies can have side effects, including injection site reactions, may have GI symptoms, or increased risk of certain malignancy. And remember that not all patients respond equally to biological therapies, and some may require a change in medications. What about the monitoring and follow-up of the patient? Where patient receiving biological should have regular follow-up appointment with a rheumatologist. And monitoring include evaluating the control of ankylosing spondylitis symptoms, assessing for side effects, and monitoring this using the Bath Ankylosing Spondylitis Disease Activity Index. Another one is Bath Ankylosing Spondylitis Functional Index. Routine blood tests are often performed to monitor for potential side effects, including complete blood count, liver function tests, and markers of inflammation. So remember, overall, the choice between the disease-modifying anti-rheumatic drugs and biological therapies and the decision to initiate treatment is highly individualized and based on the patient-specific disease monitoring, specific disease characteristics, and respond to previous treatments. So regular follow-up and close monitoring are crucial to assess the efficacy of these medications, manage the side effects, and make necessary adjustment to the treatment plan. So I think I have given enough insight about the management of ankylosing spondylitis. So let's move on to our presentation now. So once you have taken all the history, you have done the physical examination, remember you will be observed throughout this period, then how you will present the case. While you are doing it, you should brainstorm and think about all the points which you are going to mention in your presentation. So, good day. I like to present a case of 32-year-old male with ankylosing spondylitis. So this is the introduction. Then you talk a bit about the patient demographics. This patient, 32-year-old male, presenting complaint. He presented with the chief complaint of lower back pain and stiffness, and then you go to the history of presenting complaint or history. So we provide a concise overview of the patient history, including the onset and duration of the symptoms, their progression, any exacerbating or alleviating factors, and any relevant family history. So we can say like this, that patient lower back pain and stiffness started inside the sleeve in 3 years ago. The pain is mainly in the sacroiliac region and is more pronounced in the morning and after periods of inactivity. He also has noticed reduced mobility, particularly when tying shoelaces. His sister has a known diagnosis of ankylosing spondylitis. So here the patient has, when you asked about the family history, he has volunteered that the sister is already diagnosed with the ankylosing spondylitis. So remember this, first of all, in your presentation, we do the introduction, we talk about patient demographics, presenting complaint, and the history of presenting complaint. And then you'll move on to the examination finding. So you summarize the key findings from the clinical examination, including the signs of inflammation and limitation of mobility. So you say like this: on examination, I noted reduced lumbar spine mobility and restriction of chest expansion. He had tenderness over the sacroiliac joints, and Schober's test revealed limited lumbar flexion. So in the exams, remember, be very precise and to the point, so that the examiner knows that you know that what points are important and what should be talked about and what should be presented. So after the examination findings in your presentation, you will go to the differential diagnosis. So briefly mention the differential diagnosis considered and the rationale for suspecting ankylosing spondylitis over other conditions. So you say something like this: in considering his symptoms, ankylosing spondylitis was strongly suspected due to insidious onset, morning stiffness, family history, and physical examination findings. Then once you have put your diagnosis, you move to description. Describe the investigation performed to confirm the diagnosis. X-ray of the sacroiliac joint revealed characteristic finding of sacroiliitis. Sometimes the patient, if when you are asking about any test done or any radiological examination done, the patient may volunteer the information. They will give you the card which may have the information about the previous test done or maybe X-ray done. If in that case, then you will mention this. Then after that, you go to the diagnosis. So based on the clinical presentation, examination, radiological evidence, the patient was diagnosed with ankylosing spondylitis. Okay. So once you put the diagnosis, then you'll talk a bit about the management. So outline the management plan, including medications, NSAID, DMARD, or biologic, physical therapy, and lifestyle. So you say like this: patient was started on NSAID for symptomatic relief and advised on importance of physical therapy. He was educated on the role of lifestyle measures in managing ankylosing spondylitis. Now remember that I put all the points, but the examiner may stop you at any point and will ask for the question because the time is limited. So finally, the conclusion, summarize the key points. So in conclusion, ankylosing spondylitis is a chronic inflammatory condition that primarily affects the axial skeleton. Early diagnosis and appropriate management are crucial in preventing long-term complication and improving the patient's quality of life. So this is just a rough sketch how you should do your presentation. But obviously, if you have your own ways and which works for you, that is fine. But remember all these points because these are important while you're doing the presentation. So finally, I'm going to talk a bit about the questions which are commonly asked. So examiner may ask, what are the typical clinical features of ankylosing spondylitis? So one of the response is here. So typical clinical features of ankylosing spondylitis include chronic low back pain and stiffness that is more pronounced in the morning and after periods of inactivity. Patient may also experience reduced chest expansion and limited spine mobility. In some cases, there may be involvement of peripheral joints, uveitis, and there may be some family history. Okay. Now the examiner may ask, what are the key radiological findings in ankylosing spondylitis and how do they contribute to the diagnosis? So the key, this we have already discussed. The key radiological findings in ankylosing spondylitis include sacroiliitis. So sacroiliitis, which can be visualized on the X-ray. This is characteristic. This is characterized by erosions, joint space narrowing, and sclerosis of sacroiliac joints. And these findings are essential for confirming the diagnosis of ankylosing spondylitis when combined with clinical symptoms. Another question which could be asked: what is the rationale for starting this patient on NSAID as part of the treatment plan? Well, NSAID, these are the first line treatment for ankylosing spondylitis, and they are used to relieve pain and reduce inflammation, which can significantly improve the patient's symptoms and quality of life. Additionally, they can help delay the disease progression. What about the role of physical therapy in the management of AS and how it can benefit? The physical therapy also plays a crucial role. It helps maintain joint flexibility, improve posture, and reduce pain. Specifically for this patient, it can address limitation in the lumbar spine mobility and chest expansion, thus improving function and quality of life. Okay. Now, another question which examiner may ask, what are the potential side effects and limitation of used biological therapies in the management of the ankylosing? This we have already discussed in detail. So biological therapies like TNF inhibitors, these can be highly effective in treating ankylosing spondylitis. However, there are certain potential side effects, including an increased risk of infections and reactivation of latent tuberculosis. They can also be very expensive. So not all patients respond equally to these medications, and some may require a change in medications. And finally, why is early diagnosis and management important in ankylosing spondylitis? Well, early diagnosis and management, these are crucial because it can help prevent long-term complications, and these complications are spinal fusion. It improves the patient quality of life and delay the progression of the disease. So effective management can alleviate pain and stiffness, allowing patient to maintain their mobility and function. So, my dear doctors, this was all about the ankylosing spondylitis. Hopefully, I have covered everything and have given you some idea about the presentation and how to approach this case. Thank you very much. Please, I request you again, if you want any topic to be discussed, please put in the comment box so that I'm aware, and I'll try my best to make a good presentation for you on that one. So thank you very much and take care of yourself.